All right, we'll get going. Thank you all for coming. Thanks, Olivia, and thanks to John. So I'm Alan Thomas. That's me. There are cameras here. You will not be filmed. You're okay. All right. Don't worry. So we're going to play a video here. If you get bored with me, you can watch the video. That's a unedited sleeve gastrectomy. Okay, in real time. It's not live. It's something I did in September. Patient was happy with her photos or her video being shown here. It's de-identified. Feel free to watch that if I bore you. I'm just going to keep going. Feel welcome to interject if you want and ask some questions on the way. Otherwise I will just babble on for a fair while. So I sit on two medical quality committee, both here and at the Mount. So this is going to be about the whole aspect of obesity and with I guess a safety angle to it. These are discussion points we want to get through. What's the scale of the problem? Why is there a problem? How can it be treated? How the operations work, and it won't be what you've read, okay? They do not work the way that people think they do, and even surgeons think they do. What to do after surgery, why a surgeon matters, and why follow-up matters. Okay, so the scale of the problem. This is pretty much what we're talking about worldwide. These are graphs, and as you can see, every single country in the world, as they get westernized, the problem of obesity goes up, and not only is it going up, but the pace at which it is going up is also speeding. And if you take those three together, or those four together, you'll see that the most populous nations on earth are in there. That is a massive issue occurring in the world at the present time. The Pacific Islanders come off worse, followed closely by the United States, Australia, UK, etc. I haven't got these graphs for Australia because they don't exist, but this is what's happened since 1994 to 2015 in the United States. If you pay attention to the, this is diabetes, obesity, and the graphs of percentages. This is what's happened, okay? So that's in the space of, 15 years or so. So that now what we're faced with is 1 in 5, and this is overweight or obese, not just obese, 1 in 5 2 to 4 year olds, 1 in 4 5 to 17, 1 in 2 young adults, and it comes to about 60% of Australia's population are either now overweight or obese, which technically means that the norm is overweight or obese, okay? Now, this wouldn't be a problem for society or governments, okay? They wouldn't care, all right, unless there was issues associated with it. It's a bit like COVID, all right? Unless COVID was a major issue, no government would have done anything about it. So the problem with obesity is that people die. And if you look at these two graphs, both in men and women, as the weight or the BMI goes up, then the number alive at different ages goes down, okay? And the more you weigh or the higher your BMI, the greater your risk of dying. Now, if you're going to be absolutely harsh about this, that also wouldn't be a problem for government, okay? In fact, government would actually like that, because if you work up and die earlier, that means that you don't use up as much of your pension. All right, so that is actually a very good model for society if you were a politician. All right, but it's what happens because of the obesity that gets the government and everybody else worried. There's now over 200 medical conditions. This was published by Harvard, associated with obesity itself, ranging from all these cancers, and there's a lot more than those. Probably the single most important factor for all of those cancers. Cardiovascular disease, significant increases, and I'll show some data on that. Problems with respiration, and of course orthopedic issues are quite enormous. Just from a knees perspective, you don't do very well. If you're obese from knee operations, earlier loosening, increased pain, you don't get as much benefit. Just some data, 33 times the rate if your body mass index is 40 of needing a total knee replacement, and it's about 10 years younger as well. And if you have a knee replacement earlier, you will have your replacement knee earlier as well, and there's more problems with that. So 5 times the rate of revision. I see a lot of patients and they come and they say, you know, I'm going to have my joint prosthesis done first before bariatric surgery because then I can exercise along with my weight loss. It doesn't happen, okay? All the data shows that weight actually goes up if you're obese and you have your joints replaced rather than the other way around. Hips, major issue for revision. Back pain is probably, I see an awful lot of patients being referred from the back surgeons for treatment rather than have their back surgery done. It has a massive impact if you can lose weight on your ability to function. I'll skip over that. Last time I was in America, which was a couple of years ago, the plenary lecture on this, and this is the biggest meeting in the world, was done by a cardiovascular consultant, and he was very articulate. He said the average BMI in CCU is now 34. He pointed out that Asians, if 22.6 is the same as an obese Caucasian, okay, you don't see that in the data either. And if it is actually the size of your waist that's more determinant of your cardiovascular risk rather than your body mass index itself. He pointed out that you know, a bit of weight loss makes a massive difference to your blood pressure. And if you drop your blood pressure, your risks of dropping dead from heart attacks or strokes decreases quite significantly. Your cholesterol is improved by weight loss. And he pointed out that diet and exercise has no effect overall because people can't maintain it, okay? He championed the cause of bariatric surgery. He says it was the best data out there, and in fact, look at the data. He said it's fantastic, and he concluded that they should get better medications out of all that, having made the case. But the reality is it should be everything that's available for treatment. All these have been associated with increased prevalence of diabetes, but all of these together don't match up to the effect of BMI for the development of diabetes. And just to give you some idea, 93 times the rate if your body mass index is in obesity class 2 than someone whose body mass index is 25. So all we do as surgeons, irrespective of what people tell you, is pretty much this is the definitive paper in the world that came out on the benefits of surgery, known as the Swedish Obese Subjects Study. I've never seen a study like this in any aspect of surgical life. There were just over 4,000 patients. In fact, I think it was 4,047 in Sweden. And they got divided into 2 groups. So there was the surgical group, and then there was a matched non-surgical group. And they followed all of these up for 10 years. And in all that 10-year period, they lost 3 patients to follow up, okay, which is absolutely incredible, okay. 2 patients left Sweden, and 1 was involved in the witness protection scheme, so they couldn't weigh them, all right, or contact them. But what this study showed definitively was that this is what happened with surgery over that 10-year period. This is the surgical group, okay, and the banding didn't do as well, but this banding is a fixed band, okay, not an adjustable band. This is an old-fashioned operation of EBG, and your old-fashioned open gastric bypass. This is the group that had every other intervention apart from surgery over a 10-year period. And what they lost at the end of that 10-year period as a group was 0, absolutely nothing, okay. So all this group lost weight. So obesity causes early death. It causes a lot of disease. Surgery can cause or can aid weight loss. The question is, does it make a difference? Right? And what the study showed is that it did. Okay, just after the 6-year mark, you can see there's a splitting of people that were alive or dead in both groups. Okay, so fewer people died in the surgical group, and that got more and more obvious as time went on as well. And that study is still going on. They're still following these patients up, and that curve has widened even more with a bit of tailing off. And they found that fewer people had heart attacks, fewer people had strokes, fewer people attended hospitals, they recovered better, fewer visits to the GP, etc. So there was an overall global improvement going along with the beneficial effect of weight loss as well. So from a society and economic perspective, it was deemed very worthwhile. So, bit to the point, how has this epidemic occurred? And you often see people say, well, you just eat too much or just eat less and you'll be all right. Come on in if you want. Which is an interesting view, and it fails to realise some of the issues, I think. I think you've got to apply a bit of logic and common sense to all of this. King Henry VIII is probably the best known obese individual if you go back in history. But there weren't many. Okay, if you really think about it, there's not many obese individuals if you go back in history. Henry VIII was dead by 55, he had 140 centimetre waist, bad gout, non-healing pustules on his legs, huge psychological issues. I think his mother died in childbirth, his brother died after he got married at the age of 17. I think he married his brother's wife, divorced her, married another one, killed her, married another one after that, killed her, and married another couple as well, I think. So huge psychological issues, but he was also a glutton. Okay, he ate for England. All right, this guy did eat and eat and eat and eat. So if you continue to eat and eat and eat and eat and eat, you will become that size. Okay, irrespective of what you eat, because you overcome the body's automatic control of weight. And animals' bodies control weight automatically, just like they control blood pressure automatically, just like thyroid levels are controlled automatically, within a fairly wide calorific range. All right? Now that might be a little bit of a difficult concept to gather, because you say, oh, I have full control of that, but it's not actually how it works. You are designed to overeat, and the body compensates it back to a normal weight. That is how you control weight. And if you don't believe me in that, if you actually had to do it, you'd have to control your calorific intake within half a potato chip a day to maintain your weight. Okay? So an extra half a potato chip a day, if it was pure and simple calories in, calories out, would gain a kilo every year. Okay? That's how accurate you'd have to call it if it wasn't automatic. All right? So if, from the earlier slide, if 60% plus of Australia's population are obese or overweight, are we really saying that 60% of Australia's population are gluttons? And it's not borne out by data, right? It's just not true, all right? So what's been happening? You recognize the crew of the Starship Enterprise, the original crew, okay? William Shatner, DeForest Kelley, Leonard Nimoy. So this is what they perceived Stardate 2332 to be like, okay? And if you actually look at, this is a photo I got from end of the 60s, I think, in Trafalgar Square in London. And I struggled to find any obese individuals amongst that snapshot, okay? Go forward to the crowd scenes of 2020. We didn't get many of them, all right? But one person got the trend you could rely on so old Donald here. And I had a look at this from one of his many campaigns, and immediately, all these are obese individuals, okay, just as a snapshot, including the Donald Trump himself. So this is a modern phenomenon, okay? something has happened clearly since this era to now, okay? And it keeps going. And what's happened is not the amount that's been eaten, but it's the what has been eaten. So 2 macaque monkeys, okay? Both are wild monkeys, all right? Except this fellow here, he's found where the rubbish bin is, okay? And he eats human leftover food. And so that is the outcome. He's still a wild monkey, not a pet or anything, okay? But that is the outcome. Same species. So it's our food that's causing the problem. This is a modern phenomenon. What is it about the food? So here's a kind of straight off the press slide, really. Just to orientate you, the blue here is DNA markers. So this is inside the cells, okay? This is the cell wall. This is mucus in the gut. And if you look closely, there's little dots in there. They're bacteria, okay? So if you buy products in a supermarket, they will almost invariably have carboxymethylcellulose or polysorbate 80 on them. They're both emulsifiers, okay? And emulsifiers are biologically active. They will emulsify you. And the net result is this, okay? These are emulsified gut linings. That's normal. Mucus protective barrier. The mucus barrier has been destroyed here. It's almost completely gone here. And again, if you look closely enough, there are bacteria here in pretty much direct communication with the lining of the gut. And that's not supposed to happen. When that happens, you get exposed to live dead bacteria, cell walls, antigens that you were never meant to get exposed to. So there's a damage to the gut. There's the development of autoimmune diseases, allergies, ADHD, autism, weird and wonderful conditions that only seem to exist in countries with mass-produced foods. I'm not saying it's the only reason those conditions exist, but all those graphs go together, all right? So there is a damage to the lining of the gut from the modern processed diet is what happens. And when you damage the lining of the gut, it fails. Other additives, high fructose corn syrup, or fructose 55 as it was called when Richard Nixon bolstered the American corn industry in 1970. Excess corn in the world, they fed farm animals on fructose 55, corn slurry. And when they did that, 80% of the farm animals ballooned in weight, okay? But then they added it to human food, and 80% of the animals that fed off that as well ballooned in weight, because it changed the gut bacteria of those animals and us, okay? So this is a double whammy at least of a change in the gut bacteria and a damage in the lining of the gut, and the net result is that the automatic body control of weight is damaged, and so you get the disease process of obesity, not the lifestyle issue of obesity, okay? So, operations. Now, even if you go on the biggest website in the world, which is the ASMBS in the United States, you will find that there are restrictive operations and there are malabsorptive operations, okay? Or a combination thereof, and they put great little spiel on them there and tell you exactly how it works, and that's probably what you will have read as well. But we were completely wrong, okay? That's how we thought they worked. That's how they were kind of rationalized. Let's make a pouch here and do this and do the replumbing, but it's not how they work, okay? You cannot translate animal experimentation to humans because humans can adapt, okay? You can change the way you eat. Animals don't tend to do that, okay? If you give an animal a meal, it will kind of eat and it will move on, okay? Humans can change the speed that they eat that, they can change the consistency, they can change the calorific content, so it can't restrict volume and it can't restrict calories, nor can it cause malabsorption, okay? if you had a look out there, there were 3 gastric bands that I put out there from various companies. Australia's a little bit different from the rest of the world. Okay, Australia became very much a bariatric country. Obesity surgery is not well taught in Australia at all. And so a company came along and dangled a gastric band and went, we've secured a code, which was the old-fashioned big open operation that I mentioned in those previous studies. And they said, it's the same code, but you can do this one laparoscopically, and you can do it in a day, and patients are out in a day, and actually you can then take the band out, and that's the same as doing the big old-fashioned operation and taking it apart again, and patients are out in a day with that as well. And so this kind of bariatric surgery came to fore in Australia, which is why the bands took off, right, at the expense of other operations. I did most of my training in the UK. I did do some of my training in Australia as well. And I happened to work in an institution where we did bariatric surgery, and one of the very few, I think there were only 5 centres in the UK. 2 of them happened to be in Sheffield, and I trained in Sheffield at that time. So although we did start doing the gastric band, it was in the context of other operations. And what you found with the gastric band is that people kind of just, my weight's not going down, put more fluid in. Okay, oh yeah, no, I'm all right, more fluid in, all right? And what you ended up was people losing weight because they just vomited. Okay, they couldn't get anything down apart from liquid. And that is really bulimia by band, all right? Rather than put your fingers down, it would occur automatically. And there have been tens of thousands of bands placed in WA alone, and they're going to be coming out. Not all of them, okay? It can work, it has a specific way, but it's for a very, very tight, specific group, I think. So these operations are really the ones that have taken off since then. Those are the same operation. Single anastomosis bypass, mini bypass, omega loop is the same operation. You may or may not have heard of this one. Anybody heard of Mangerstrassen-Mill operation? No? It actually came before the sleeve gastrectomy. All right? But I'll tell you a bit more about that in a bit. All these are the same operation. Okay? So whatever you see people say, that's the same, okay? It's a single anastomosis duodenal ileal bypass or a single anastomosis pylorus preserving sleeve, whatever acronym you want to put on it, they're the same. Those two are the same. But these are going down in increasing complexity. And the more complex the procedure is, the more your body is altered because of it, the more the side effect profile. Okay, make no mistake about that. These have profound effects on the body and need a good deal of monitoring. But they all have one thing in common. They all involve some degree of stapling of a stomach in a similar pouch shape, okay, with or without removal of the stomach, and then replumbing what's underneath. That's pretty much what it is. Okay, so all those operations, they're there to describe various forms of stomach stapling and replumbing. All right, if you think about it simply. So that is the standard staple line for a sleeve gastrectomy. Okay, long, thin pouch. Okay, and you remove this part completely. And what you're left with is this portion, which is a sleeve of stomach, hence a sleeve gastrectomy. Okay? That operation was first performed in 1999 by mistake. All right? It's actually what happened. So they had a young girl on the table that they were going to do a duodenal bypass on, which is a massive replumbing procedure. And she became unstable cardiac-wise on the table. So after doing this part, they abandoned the operation. And what they found was that she lost a good deal of weight when she recovered, and they kind of went, well, why are we doing the other bits underneath? Not quite as much as she would have done, but she lost a significant amount of weight, and that's where the sleeve started life, in 1999. Okay, a guy called Jossard did the operation. All right, so if you look at the shape of this long and thin pouch, that's a Mangerstrassen-Mill. long thin pouch, staple lines like this, and that stomach is effectively split in a V shape, but it's not removed. Okay, this was done at open operation in Leeds, and they published their data in 1999, the same year as the sleeve gastrectomy was discovered. All right, and it was done by open surgery, so everybody forgot about this operation because you had an open operation that was difficult with actually pretty good results, and then the sleeve gastrectomy that was done laparoscopically. So the laparoscopic version took off, and you couldn't do this operation laparoscopically at the time, so everybody forgot the data. Okay, but that is a sleeve gastrectomy. Sorry, that is a Mangenstrasse mill. Anybody know any German? No, I think Mangenstrasse mill means stomach road to the milling area, something like that. Okay, so it's a long stomach road to the milling area, which is essentially what the sleeve gastrectomy is. All right, and food will not go down here and back up there. Doesn't happen. All right, so it just keeps on flowing in this direction because your propulsive wave goes down. All right, so it works in exactly the same way as a sleeve gastrectomy. All right, now you can do it laparoscopically. That is the same week as I did this operation. This is a Mangenstrasse mill. All right, hole in the stomach, in the middle, stapled, long thin pouch up, and that bit of stomach just stays in. Okay, and the results, not that it's done that often, but the results from the Leeds study were about 60, on average about 60 to 70% excess body weight loss, which is on par with what a sleeve is quoted as doing. Okay, long thin pouch. It's just cut across here and the stomach is separated. That is a pouch for all bypasses. All the same, same shaped pouch. And it's if you carried it on down, it would be a sleeve gastrectomy, okay? To convert a sleeve gastrectomy to a bypass, you just need to staple straight across. So same pouches, everything is the same in that stomach. And then you just add this component onto it, all right? So small bowel and large bowel. So quite a variable length, okay? 3 to 10 meters, which is highly significant if you don't measure it. And if you think that every surgeon measures it, you're wrong, okay? They don't, okay? If you start measuring from this end and measure 100 to 200 centimeters, okay, these is what you do with a roux or a mini bypass, okay? If you're measuring from the bottom end here up to 300 centimeters, you are performing these procedures. Problem is, if you measure from here and you've got a really short gut, what you've effectively done is created these type of procedures because the gut may only be 3 or 4 meters long, and you've bypassed a significant portion of this, thinking that you're only doing a very short bypass, okay? So there's lots of that may be happening out there as well. You won't know that until patients come back with a lot of vitamin issues, all right? So, but these are foregut operations, these are hindgut operations, work in slightly different ways. That's basically reiterating what I said there. So, how does a sleeve gastrectomy work? Sleeve gastrectomy is the most popular operation done worldwide and has been since August 2015. Okay? Before that time, the most popular operation was a Roux-en-Y bypass, done laparoscopically. And again, a Roux-en-Y laparoscopic bypass was first done in 1992 in the United States. So well before sleeve gastrectomies came in. Okay? By a guy called Alan Whitgrove. So I said it's not a restrictive, it's not a volume restrictive operation in the true sense. This is what happens. Think of your stomach ordinarily like a balloon, ordinary balloon, okay? And you start cutting bits up, long, thin pouch. You're converting it to this shape, all right? And from your balloon blowing up days, you will know that it's more difficult to blow that up than it is to blow one of those up. In which case the pressure inside these is slightly greater. In which case the pressure inside a long, thin pouch, this bit having been removed, is slightly greater. And that is all it takes for you to lose appetite. Okay, so it's a slight increase in pressure at the top part and your appetite goes. Now I know lots of you may have heard that if you remove this part of the stomach, you remove the ghrelin area, which is the hunger area. It's probably a net result of rather than a cause of, okay? Is probably what happens, because you hear of people getting hunger back. And if you removed the secreting area, how can you get your hunger back, okay? So what happens is that increase in pressure there is enough for you to lose your appetite. If you then think of food going down or liquid going down, you get little pulsations of pressure waves inside, and that makes you satisfied. All right? It fools the body into going, I'm fine, I'm okay. All right? It won't stop you putting more in, okay? The key is don't, all right? Anyway, so pressure changes. If it's performed accurately, it will look like that, which is, I guess, where your surgeon comes in. All right? So what happens? Content moves down very quickly. So a sleeve is a rapid emptying system, not a rapid filling system. All right? So your sensation of being full after surgery is not your stomach being full. It's your stomach having emptied quickly, and then you get feedback mechanisms, okay? If your sleeve's done like this, like those balloons, then you get differential pressure gradients in there. You get food accumulating up here, okay? You get reflux occurring. You can get hiatal hernias occurring, okay? And they can be difficult to form. It may be that there's previous surgery in there, bad scarring. It may scar in this direction. It doesn't necessarily mean to say it was performed like that, but it may end up like that, okay? And you get poorer outcomes because stuff is not flowing through properly. You're not getting the pressure feedbacks. Which is why the training's important, okay? If you look at your surgeons, the average surgical training in Australia, 4 to 5 years medical school, another 4 years you can be a consultant. Okay? If you've never had an upper GI term, you will have never operated, in all probability, on the esophagus and hardly ever on the stomach these days. It's not like back in the 70s where people got ulcers the whole time, and the commonest operation, apart from an appendix, was we opened people's belly and we stitched up the holes in the stomach because of ulcer disease. That hasn't happened. So the current generation hardly ever operate on the stomach and will pretty much never operate on an esophagus, okay? Unless you're an advanced trainee, you won't do advanced laparoscopic surgery on that area either. You're kind of limited to appendix, gallbladder and a few hernias really. And you won't laparoscopically stitch on the whole. Endoscopy training is very haphazard in Australia, and you need endoscopy training to be able to do and manage these conditions. And I would tell you that you can't do a fellowship in addition unless you finish the beginning bit first. It's a bit like learning how to drive an articulated truck when you actually haven't passed your driver's test for a car. Okay, it is not necessarily a good idea. When you're choosing your surgeon, choose them wisely. There's over a 10-fold difference in complications in town. Check their facts and claims, okay? They're not allowed to lie to you, all right? Ask them how many operations they do in a day or a week, all right? Because there are people that do 14 of these in a day. I'm not a slow surgeon, okay? This is the pace, okay? And you're seeing a sleeve gastrectomy in real time here. If people are doing 14 of these in a day, just, if you think that's a good idea, fine, but I don't. And if you don't think there's an issue, then bariatric indemnity in the last year has gone up in Australia by 40%, okay, because of that. Not allowed to lie about their training, okay? Websites aren't allowed to have testimonials on, right? It's illegal, but the majority do, okay? Not allowed to do trials, so you can't have a staple here and a no staple there and various things. Not allowed on Medicare, right? Illegal, okay? Not supposed to use these kind of terminologies on your website either, but people do, right? And you can't have a picture of a model there and say this is a realistic picture of, right? Not allowed, but people do, okay? And you can't directly advertise yourself, but you might have seen full page spreads in the newspapers say, come and see me, 50% off if you get somebody else in, right? You're not allowed, it's illegal, all right? But it's happening. If they're doing that, what else are they doing, okay? Ask them. So I would put it to you that, poor shaved sleeves, now it can be, as I said, it can be scarring, it can be the scarring's occurred afterwards or previous surgery in there, but your standard primary operation is more likely to be a surgeon issue, okay? And these things then occur, all right? You don't get as good an outcome, you get more dilatation of the stomach, as you'd expect. Right, some more ways in which a sleeve works, all right? So, it empties quickly. Because it empties quickly, you get pressure changes very quickly here. When you get pressure changes in that area, then receptors send messages back to the stomach and say, stop moving, because that part of the intestine receptors thinks that the whole stomach is still there, and this amount has already come through, right? So your stomach must be jam-packed, and that's already come through, but it hasn't, okay? But it sends message to your stomach, stops the stomach moving, make you feel full, sends a message to your brain to say, stop eating, okay? It can't stop you eating, though. And if you think, oh, I wonder if I can get another mouthful in, yes, you can. Will it be uncomfortable? Yes, it will. Will you vomit? Possibly. Is that good? No, all right? But it can't stop you. So if you think of bariatric surgery as a cosh, preventing you consuming volume or calories, you will fail because it can't, okay? So pressure changes there affect your feedback, affect satiety, keep you satiated for a long time. I'm not sure that's the correct term, but anyway, you don't feel hungry for a long time. Okay. Also, you'll see that the bile duct empties into here, the pancreatic duct empties into there normally, and some digestion would occur in the bottom part of that stomach. But of course, the stomach is now emptying very quickly and things flow through this area very quickly. So the partially digested food that would normally have time to continue its digestive pathway along this area really is not the same as if you hadn't had a sleeve. And that gets picked up by various receptors in that area. And because of that, hormones flip over.
Transfer C, ED to south wing, commencing now.
It's a COVID transfer, stay here, okay? All right. So hormones change in the gut, all right? And they profoundly change. And they are all beneficial. So insulin levels improve. Control of cholesterol in the body improves, okay? There are changes that affect blood pressure, etc. All because this area picks up those different levels of partially digested food in a different way, okay? Pure coincidence, no surgeon ever designed the operation to be that way, but we will all take the accolade for it, okay? So it's not a volume restriction, it is a profound hormonal changing operation. I've seen a patient on 330 units of insulin leave hospital 3 days later on no insulin whatsoever, okay? That is not weight loss. That is profound hormonal changes occurring here, okay? So how does the sleeve work? It causes pressure changes, flow changes, receptor changes, hormone changes in your body, okay? It also changes your taste, all right? Believe it or not, you tend not to like sweet stuff after something like a sleeve gastrectomy because the way you perceive taste depends on what you put in your mouth and what dissolves it. And what dissolves it is saliva, and saliva has hormones in it. And the hormones are changed by this operation, okay? So taste changes. People often say they can taste water. It tastes different after an operation, and they tend not to like water, believe it or not. Tend to like add something in. The reward from food also goes down, okay? So profound changes in the body occurring because of surgery. And if you actually think about it then, it's effectively bypassing that bit of the gut because stuff goes through so quickly. So a sleeve gastrectomy is a functional foregut bypass operation. It's the same operation as a Roux-en-Y bypass or a single anastomosis. Okay? It works in exactly the same way. It changes exactly the same hormones. Slight different degree in them. Might be a couple of kilos different here and there. Might be slightly better control of insulin with one or the other with the functional one. But the more complex your operation, then the more effect it has on your body, the more you need to maintain it, and the greater the side effect profile. Okay? But they are the same operation. So converting a sleeve to a bypass does not cause more weight loss, all right? Because they're the same operation. Now, because of all those kind of fundamental changes in your gut, so pressure changes, flow changes, hormone changes, receptor changes, taste changes, etc., then there is this that occurs, right? Temporization of thermogenic adaptation. It's got to be good, right? So it's a big term, right? Medicine, we love them, right? Okay. What does it mean? If you've been on a diet, all of you will have experienced thermogenic adaptation, all right? Your body adapts knowing that you're restricting calories. It gets more efficient at holding on to those calories, right? Is what happens. That's thermogenic adaptation, all right? But if you have a sleeve gastrectomy or the other operations, then you get a temporization of that. It's held back. It's held at bay. The body fails to adapt to being on a diet. So to put it in a simplified way, if there are two identical twins, one has an operation, one doesn't, they start off on the same weight and they both diet to the same degree and they both have the same general activity level, the one that's had the operation will do this in weight loss compared to the one that doesn't. They will lose significantly more weight. There's more bang for your dieting buck, if you want to put it that way, simply because of the fact that the operations occurred, right? It's nothing to do with the way things are absorbed. Same calories in, same calories out, but the body deals with those calories in a different way because of those profound changes that occur, all right? But that is optimized in the first 6 to 9 months after surgery. That's when that's at its greatest. People are more motivated, all right? So you have this kind of golden window if you have surgery to lose weight of about 6 to 9 months in duration. And all studies have shown that it's highly unlikely that somebody will lose significant weight after 9 months after foregut bariatric surgery, okay? So whatever your target weight is, if you're considering surgery, you have to hit it in that period of time. All right? So this is not about joining hands, singing Kumbaya around a campfire and let's take it nice and easy and lose weight. This is profound, hard, dedicated, targeted weight loss over a defined period of time. Then we can join hands and sing a song when you're down there and do the fine tuning. You will not fine tune your weight down, okay? It just will not occur. And that's pretty much what I said there. Now, the other interesting bit is the first 6 weeks is highly indicative of where you go. So it's a bit like getting a brick at the bottom of a swimming pool. Running jump straight down is the way to go, okay? Your angle down in the first week is highly predictable of where you'll get to. It's almost like the dive down, all right? So I say to people that contemplating this surgery, say, this is a year of my life. This is about me getting to my goal. I will get prepared for this. Everything will be about me getting to my target area, okay? Hit it hard, and keep hitting it. And that's pretty much what I'm saying here. Your aim should be to get to normal weight, right? Okay? Don't listen to other people, okay? That's their experience. Okay, if you're contemplating this, do it the way that suits you, all right? And if what they said worked, right, or what society said worked, then people wouldn't be where they are now anyway, right? So, you know, people tell you to eat meals regularly, okay? Why? Okay, yes, it was required when times were hard, right, and you only had a fixed time to get nourishment in, or you had, you know, 12 kids and you wanted to make sure that one of them was alive to look after you in your old age, so you had your 3 square meals a day. But that's not the issue in the modern era, okay? And there's not an animal in the world, I would put it to you, that eats 3 meals a day by the clock, okay? It just wouldn't do from an evolutionary perspective. And even if you're religious, there were no clocks in Adam and Eve's time, right? So they could not have eaten by the clock either. Okay. So, you know, a few pointers that I tell people, you know, do get support, okay? But expect them to kind of say, you know, oh, is that all you're having? Or, you know, oh, you need more than that. Or you look terrible or whatever, okay? Because, you know, on the whole, people are used to seeing obese individuals, okay? Because that's what society has gone like now, all right? There was a GP friend of mine last year who, a couple came in with their kid and they had an issue, and he actually was more concerned about the kid who he thought was malnourished, right? So after kind of fobbing things away, he kind of made an excuse to weigh and measure the child, and the child was smack bang in the middle of normal weight, okay? Because he got so used to seeing children that were overweight in the surgery, okay? So, you know, COVID, right? What went first? Pasta, right? Why? Because everybody knows that that will hold you, all right? Carbohydrates maintain weight. Every major culture in the world has done that, okay? They have a carbohydrate to maintain weight. So get rid of that, you know, if you're contemplating surgery, don't buy it. If you're the person that buys it, stop buying it. If there's somebody else, get them on board, stop them buying it, okay? And here's the nice tip, okay? Make a conscious effort. Leave something on your plate. Even now, you'd be surprised how it works, okay? That you just get used to it. There's a big psychological thing, because, you know, I was told, like everybody else, finish everything on your plate. Think of the starving children in whatever it was, Bangladesh, I think, when I was growing up, and that's what we were told, right? So, you know, which was appropriate when times were hard, but that's not what we're trying to achieve here. Okay, so this is advice I give people during, or how to succeed, really, okay? So we know that there's this golden window of 6 to 9 months. But you've got to lose, you know, this might be a phenomenal amount of weight to lose, but you've got to do it safely, right? There's no point in doing this if people are going to come to harm, okay? So you've got to give your body what it needs to be okay, right? And the body needs, you know, about a litre and a half of water or water-based products per day in a normal environment. Obviously, the more you sweat, the more you need, right? Now, you know, the food pyramid that dietitians love, politicians love, okay? 100 different ingredients, at least, okay? If you have exactly the right amount of all those for exactly the same meal at exactly the right time for the rest of your life, you'll be okay, all right? Does anybody eat like that, okay? I don't know why we're trying to practice that, okay? I understand the theory, but it's not practical, okay? So, why did your mum or dad tell you to eat carrots? Why do we eat carrots? Good for your eyesight? Yeah, do you know why? There's a minuscule amount of vitamin A in a carrot, okay? Right? Also helps your skin, as it happens if you eat, you know, about a bag like that on it, okay? So yes, they are good for your eyesight, okay? But, you know, there's a tiny amount of vitamin A, there's a good deal of sugar, carbohydrates, which is why they're easy to caramelize, and there's a bit of fiber that makes you go to the toilet, right? Okay? So if you hadn't got that fiber, we say to people, well, take extra fiber then, which is a natural product to make you go to the toilet, right? But you say, well, if you don't have the carrot and the sugar, you can just have the vitamin A, and it's all of a sudden, oh no, yeah, but it's like it's unnatural. Well, no, it's not. It's actually derived from the carrot, except it hasn't got the sugar in it, okay? So take a multivitamin. Right? That means that food pyramid is pretty much covered, all right? You don't need anything else out of it. I'm not saying don't have anything else, but you don't need it, okay? You're safe. This is about being safe, all right? So multivitamin, litre and a half of fluid, and the average human needs that amount of protein a day. And the reason protein is important in the diet is because humans cannot produce protein from their own fat stores. Okay, we don't have the necessary enzymes to do it. And we are losing 40 to 50 grams of protein every single day from our body. Hair falls off, skin falls off, we secrete enzymes into our gut. So if we're losing 40 to 50 grams, we can't convert the fat stores to that, we have to replenish it, or we will become protein deficient. Okay? And you won't do that overnight, you won't do it in a month, you won't do it in 6 months. But going to a year to a year and a half, you will become protein deficient. And that's why you see people with, kind of the marasmic look where they're very, very thin, or the pot-bellied pictures that you used to see. That's protein malnutrition, okay? So your body will use its own source of protein because it's losing protein, and the body's source of protein is muscle. So the muscle mass of the body goes down, which is why dieters tend not to get, the yo-yo dieter tends to get worse, because the protein content of the diet is usually small, so you lose more muscle mass, so your car engine size goes down, okay? So if there's no protein, your body uses up its own muscle, and then when it finishes using up its own muscle, it will use the other muscular organ, which is your heart, and then you die, okay? So ultimately, protein malnutrition is a big issue. So you need at least that amount of protein a day. You'll be okay on that. The big operations, though, you need twice that level of protein, because you will leach protein out of your body with the other operations, the hindgut operations I mentioned. Remember, the more that's done to you, the greater you have to do to maintain things afterwards. Okay, so your SADI or your SIPs and all these procedures need a greater protein intake. And if you don't, you come in sick, all right? And we see them regularly. So don't eat conventional times is what I tell people, okay? And, this breakfast, most important meal of the day, nonsense, right? Okay? Cereal manufacturers make them very rich, and the world, got big as a consequence, all right? So what's the key? It's this. Work out how you get 40 to 50 grams of protein a day in the minimum amount of additional calories. When you're not feeling hungry, you feel content quickly, content for a long period of time. Okay? Don't eat regularly. Everything you put in your mouth is a meal, not a snack. Okay? It's a meal. Okay? And this concept of a balanced diet, right? There are no essential carbohydrates at all. Your body can convert its own fat stores into whatever carbohydrate product it needed, okay? And it can also convert its fat stores to any fat product it needs as well, so long as it's got a bit of liquid on board and some multivitamins, all right? So in essence, there are no essential carbs or fats, okay? It's not strictly true. There are a couple of fatty acids that are essential, but every foodstuff has that, okay? So if you're getting protein in, you've got those automatically, all right? So and don't eat regularly, just plan how you get protein in if you're contemplating surgery, okay? Because it's about you, right? It should be about you, not what society told you to do, okay? And I say to people, I don't care if you walk around with half a chicken all day, right? If it works for you, who cares, right? It's about a goal-driven bit. Be okay whilst you lose a significant amount of weight, okay? And every major culture has a carbohydrate that they use to maintain weight, okay? And unfortunately, alcohol is a carbohydrate as well, all right? COVID has seen a big increase in carbs, all right? So by all means, stay active, all right? Stand when you can stand, walk when you can walk, okay? All exercise is good, all right? If you can do it without hurting yourself, though, all right? Because it does all these things. But what it doesn't do is cause weight loss at all. It has nothing to do with weight loss, all right? That may be good or bad for you, depending on how your exercise inclination is, all right? That was an exercise physiologist that announced that in a meeting in the United States about 18 months ago. He was almost in tears when he put this forward. But all exercise is good, don't get me wrong, but it does nothing for weight loss, okay? This is why, and he produced this, okay? So resting metabolic rate, non-resting, okay? Or, that means you're sleeping, that means you're not, all right? And that's kind of daily activity, which is kind of what you're doing now. People are fidgeting, sitting upright, okay? And then there would be definitive exercise, right? So your traditional model is that, right? Just exercise more, go to the gym, go on that treadmill. It tells you how much you're using up, right? Okay? But what effectively happens is that your resting metabolic rate drops down to the same degree as you're exercising, okay? So your net excess calorie usage is 0 by exercise, okay? Now clearly you could exercise forever and your metabolic rate can't become 0, but you physically, unless you are a professional athlete, you can't overcome that compensatory mechanism, all right? So it has nothing to do with weight loss, okay? Your body seems to have an energy cap, all right? Can't overcome it. Remember as well that exercise induces appetite. Exercise more, eat more, okay? That thing in the gym, right, that says if you go on me at this pace for 10 minutes, you lose 100 calories. So if you go for 20 minutes, it's 200. Doesn't work like that. Muscle gets more efficient as it warms up, okay? So the machine is also wrong, okay? You've got more appetite when you go there on the running machine. And what is there? Oh, there's a, kind of packet of chips there that was 300 calories, but I know on my machine it was 500, right? And I'm really hungry now because I've exercised. So you have the 300, but actually it was 0, all right? So you've actually consumed more calories by going to the gym. But on principle, all exercise is good, right? If you can do it safely. And if you don't believe me, appropriate thing today, right? But there you go, Friday 26, exercise, not the answer. Watch your diet. Even the West Australian has cottoned on to it, all right? It was 18 months later, but it did cotton on to it, all right? So bariatric follow-up, you've got to heal, okay? So we've got this kind of graduated period of time for about 6 weeks after surgery that you gradually reintroduce more and more solid diets, okay? Your motivation's at a peak, okay? We also know that the more time you visit health professionals, the more weight you lose, okay? Now, that's probably a thing called the Hawthorne effect. It's probably how these work, okay? Less than 10% follow-up at a year, but having said that, bariatric follow-up is only 20% per year, all right? We can't get more than 20% of people to come back after a year, doesn't matter what we try, okay? Which probably isn't going to be an issue if you take your multivitamins and have a sleeve, but which may be a significant issue if you don't take your multivitamins and don't come back if you've had another one of the operations, all right? Remember, the more that's done to you, the more you have to maintain intake in terms of vitamins, protein, etc., to be okay, all right? And if you're not getting checked out on that, it's going to be a problem. And 80% of people aren't checked out after a year in WA. It worries me going forward, okay? I picked up a scurvy in the last year. In fact, I picked up several vitamin C deficiencies. That can go in a week, B1, okay? Alcoholics get that, all right? You know, when they confabulate, alcoholics, or they kind of unsteady on their feet and people think, like, gee, they must have been drinking in the morning, okay? They may not have. It might be thiamine deficiency, all right? Because all they take in is carbohydrates. No thiamine in the diet. They may vomit as well and you use up all the thiamine. Then you get neurological consequences, okay? You start getting balance issues without being drunk. It's just the fact that your system's not working properly, okay? And then you start confabulating, right? It's called Korsakoff psychosis, okay? Or Wernicke's encephalopathy, all right? You start talking nonsense. It's like being a politician, So, and it's irreparable, and that can start occurring in a week, okay? I did a medical legal report on somebody like that in Australia, okay? That was following a sleeve gastrectomy, all right? So it can happen. This is the data currently. 50% regain 4% of their weight in 2 years, but 40% remain within 5% of their lowest weight at 10 years. Okay, and we know that's true. Gut bacteria play an important role, and life event trigger falling back into old habits, okay? COVID has been bad for people on the whole, all right? I encourage people to seek help as quickly as possible. If you're starting to fall in a hole, then let's dig you out as quickly as we can, all right? In terms of why is follow-up important, this these are the only factors, right, involved in what weight is lost. So your genetics you can do nothing about. We're all different, right? And people say the average weight loss is 60%. It means nothing for that individual, okay? Because whatever you are is what you are, okay? That can't be changed. Your surgeon skill and application, it does make a difference. If you think you can get a fine meal at McDonald's, there are lots of them out there, right? Okay, it takes time to prepare and do surgery. But I'm quite happy showing you a video of your operation if you ever come to an operation, okay? You can even have your video. So if we assume that that can't be changed, that's done okay, then these two factors are just the patient. It's the application of what I said before, and it's not about eating the same stuff in smaller portions, because it was that stuff that caused the issue to begin with, okay? So if COVID's taught you anything, keep it simple and don't bathe it in syrup, okay? Support the local economy, all right? So eat when your body says it needs fuel, good quality, non-mass produced protein with a minimal amount of additional fuss that gets you through the day, really, okay? Stop eating when you're content. Don't try and eat until you're uncomfortable, because the body will then try and adapt, okay? It doesn't like being uncomfortable, so it will try and adapt. And that's when things stretch, okay? Generally, it's not stretched by things being forced in. It's just the body adapts. It causes its compensatory relaxation. Keep active, all right? Stand when you can stand, move when you can move. Do what you're meant to do, okay? And this is what you've got to do in the context of surgery, okay? This is what I do. We're a team of surgeons. There's 5 of us, okay? All of us have done 2 years of extra training on the stomach and the esophagus, okay? I see everybody and do this kind of talk in an abbreviated fashion. You see a physician to optimize you for surgery, dietitian. I scope everybody, all right? Why? If you're removing great big chunks of people's stomach, I think it's beholden to make sure the bit you're leaving behind is okay. Or if you're doing a bypass, you can never see that bit of stomach that's been bypassed again. All right, so you better make sure it was all right to begin with. Okay, that will become compulsory. All right, it's already on the American website that they're making that compulsory as a recommendation. Okay. We do blood tests for everybody, correct the correctables before surgery, okay, and then we go through everything and then book surgery if need be. Inpatient stay 2 to 3 days. In the United States, they do these operations and you go home the same day. Okay, I've seen someone out of hospital in an hour in the United States, okay, in pain, in agony, retching, but they were paying an extra $2,000 if they stayed overnight, so they went home. They came back to the surgeon's office dehydrated the next morning, got IV fluid put up, which the surgeon got paid for, about $600, okay, from the insurance company, because it was cheaper than keeping that patient in hospital. That's the American way, all right? It might be coming to a hospital near you, sadly. Okay, so, and then follow up, okay? And then bloods at a year, repeat endoscopy at a year, and then yearly follow-up as a minimum with bloods. The company that, here will do the full set of bloods at Medicare rebate rates. And if that endoscopy is okay, then it's recommended about a 5-yearly repeat endoscopy as a check of the upper GI tract, okay? And that is obesity and modern management. Thank you for your time. I'll take some questions if you've got any. Or you're all dumbfounded.
The clamping device you had in the procedure.
Sorry?
The clamping device that you had in the procedure that was cutting, was that just cauterizing or was that cauterizing and...
So the instrument's out there, okay? What happens is that the instrument closes down and a current goes in between the jaws and seals. And then there's a trigger device on it, and you don't see me pulling the trigger there, but you pull the trigger, it gives you an audible click, okay? It whistles, and then you pull the trigger and a knife goes in between where the 2 bits have been sealed and cuts it, okay?
Just the heat and the
Just the heat on that device. Yeah, there are other devices that involves kind of, it's called a harmonic motion, and it goes backwards and forwards quickly, causes the heat and seals that, but I don't use that device, okay? That's a scalpel mechanism, and if you happen to use that side of it, even though the cutting bit's here, that's active. If you touch tissue, you'll cut it. Not worth it in my mind. That we've got a controlled environment otherwise, okay? Yes?
If you've had a band,
Yeah.
is the weight loss slower?
Yeah, it's a good question. So if you had 100 patients this side, had a gastric band, and 100 this side that never had any surgery before, took the band out, did the same operation, whether that's a sleeve, a bypass or whatever, in exactly the same manner on both of them, and you were to pick the group that would lose, on average, more weight, it would be that group that never had previous surgery, okay? That doesn't mean that an individual may not do that, but as an average, and part of the reason for that is this band is not, you know, it was put down as being a completely reversible procedure, right? It's not, okay? It scars the area intensely. It squashes the nerves to the stomach, okay? And those nerves carry on to the rest of the intestine, okay? So a bit like, you know, if you had a band around your wrist for 10 years, you'd have carpal tunnel, right? Well, effectively, you get carpal tunnel of the intestine, all right? And the bit above the band obviously has been blown up lots of times. So if I blew up a balloon and put it back in the bag, you would know which balloon I put back in the bag, right? It never quite goes back the same way, and it's easier to blow up again. So if you do something that's then an accurate bit, that top part is slightly more prone. You're more prone to reflux and heartburn as well, because there's been abnormal pressure below the valve. You may have hiatal hernia situation. I've seen patients with esophaguses, you know, that size after a band. If that doesn't go back down to normal swallowing, then there's no point in doing other surgery on them, because nothing will work. The esophagus will become the reservoir. Okay, so for all those reasons, and I guess there's a psychological bit as well. I've had surgery previously, I failed it, or it's failed me, or a combination thereof, and there's this kind of thing of it's further surgery, and it doesn't quite seem to be always as much enthusiasm as making use of that kind of 6 to 9 month window. Okay, so for all those reasons, on average, the group who haven't had surgery tend to do better than the group that haven't. Okay, not to say that the individual won't, but on average anyway. So you have to speak up. So
I've heard of people having surgery more than once. Is that a
Yeah.
common thing? Or?
Yeah, so recidivism is common, right? You know, humans tend to fall back into old habits, right? So there are several reasons that. It could be a surgeon issue, couldn't it? You could have had a poorer operation, right? So the wider something is to start off with, and the more wobbly it is, the more likely it is for that not to be a good end result, right? But you know, there is a disease process here. You know, it's a disease of obesity. It doesn't suddenly disappear, right? It's held at bay, and if you go onto a more healthier regimen that's not involving those kind of products that I said there, your body's got time to recover. But there is a fat cell mass there, right? And that fat cell mass has got to disappear over time, or the tendency is that people kind of, you know, you get this calorie creep occurring. And then the weight starts going back on, and people kind of lose the plot a little bit, and they just start pushing the boundaries a little bit, or, you know, and you know, the body is good at adapting. At the end of the day, it's designed to adapt. You know, we're omnivores, right? We're designed to take advantage of a lot of situations. But there should be. Sorry, I'll be with you. But there should be a plan, right? Okay. So if you know that you know, people do come or do require or may require further surgery, there should be a plan, right? So what other surgery can be done if they come back, right? And that's what I try and tell people. You know, there's a kind of big vogue in town to do bypasses, right? Okay. Now, that's fine. And you might see this kind of golden period of 4 or 5 years that, you know, bypasses are all the be all and end all things, right? But you've just knocked on a point. You know, people get recidivism, right? So there's an issue. So what do you do then? when you've got a bypass, right? Because you can't convert a bypass to a sleeve, all right? It's just a bypass. That's it. You've done the plumbing. You've cut that bit of stomach away, right? Or you haven't cut it away, but you cut it away from the rest of the stomach, right? And people say, oh, no, yeah, you can stitch that stomach back on. You can make a sleeve shape, but it's not a sleeve. It's a sleeve shape now, not a sleeve. It looks like that curved balloon, right? Okay. So people are going to be very limited in what can be done to them in the future, bariatric-wise, because of what's being done now, right? And I think that's often forgotten in this kind of, rush to go, oh yeah, that sounds a good idea. I'll go and do that procedure. Everything should be a balanced bit, right? You can convert a sleeve to every other procedure. It's the simplest and it's the safest, okay? I told you how to convert it to a bypass. Not that that makes sense because you won't lose any more weight by bypass, right? But you can do the hindgut operations from it. Okay, you can join things back to the top end of the gut. So your SASI, your SADI, your duodenal switch, all of those can be done if it's clinically indicated in that person's lifetime. And if things come endoscopically, you'll see there's an endobarrier device in there that's been taken off the market now. But if other things like that get developed in the future, it's going to be endoscopic. You want nature's pathway open, right? As long as possible, right? So, ask people what their plan is. What we're going to do if I come back in 10 years. Yes, sorry.
No, you're right. I just wanted to ask you if you have had a band before. What's the high percentage of, if you can go ahead with the bariatric surgery, which one does the surgeon tend to lean to after having a band out quite a while ago?
Yeah.
Is there a higher percentage in, say, the...
Yeah, so again, the commonest operation in the world is a sleeve, right? The commonest revisional operation in the world is a sleeve, okay? And again, it's because it's the simplest and safest, and all the other options are still open later on, okay? Excuse me. You'll have people that, what's the polite way of saying it, are carving niches for themselves, okay? I'm the guy that does bypasses from bands, okay? And so their practice will be predominantly a bypass-based bit, okay? Now, if they can justify that, that's perfectly fine. But ask the question, okay? And you kind of say, oh yeah, in my hands the results are better than this. Yes, but what happens in 10 years' time, okay? Reflux is an issue, okay? So if you've got a damaged valve, and the more obese you are, the more likely you are to have a damaged valve, okay? So if you've come and never had surgery before, I would repair, tighten around that area, okay? Hiatal repair, okay? Right. So if you come to surgery now and you get heartburn, okay, then we should treat you in exactly the same way as everybody else, right? Repair the issue, tighten the hiatus around. But people have gone off on this tangent of, kind of, oh no, yeah, bariatric, we should do this to them, we should do a bypass, right? Why? Okay, and we're the first to jump up and say, oh, you're being discriminatory against bariatrics, right? But yet we're discriminating by treating bariatric patients in a different way, okay? So do it logically, repair the hiatus, right, if it's an issue. If you're controlled on a tablet for heartburn, take the tablet. I'm a surgeon, I get paid for operating, right? But take a tablet, if you've had previous bands, there is a greater incidence of heartburn, okay? But that doesn't mean to say it can't be treated, okay, by one or a combination thereof. And in my mind, you can still stepwise progress, right? It's a more difficult operation. That's the reality. That wouldn't be, in the same par as doing a revision operation, okay? It is scarred, and so I don't know, this is about an hour, this video, so it would take me about 2.5 hours to do a revision operation on average. It has taken me 5 hours to do a band to a sleeve, okay, because it was so stuck down and scarred. Okay, yeah, I could show you pictures of those, but they might get scared, the kids, but anyway.
But you find all that out when you have an endoscope anyway?
No, you don't. That's on the outside of the stomach, not the inside, okay? You might get some clues on the inside, because you might see some distortion inside.
Right.
But you can go in, and oh, it looks okay, and you start dissecting, and it's like unpeeling an onion. It's layer upon layer of scarring, okay?
So what's the benefit of having an endoscope then prior to surgery?
Well,
If you can't see.
okay, so pick up a hiatal hernia, for instance. That should, if it's about a 4 or 5 centimetre hernia, that should be repaired as a separate operation in my mind, okay? Other pathology, okay, so about a month ago, 40-year-old, scoped before surgery, cancer, gastroesophageal junction. It's really early, okay? So we just removed it endoscopically. He's probably going to be fine, okay? Now, he would have lost an awful lot of weight in the year after surgery, and he would have died, okay? Because people would say, aren't you doing well, okay? Be sure. This is, you know, this is balanced surgery, right? The risk of being you versus the risk of an operation. We've got to make that operation as safe as it can be.
I've got another question.
Yeah.
Is
How
there
cost-
an instance where the bypass is more suitable for a patient than a sleeve?
Yeah. Okay. So my view on that, I would almost universally offer a sleeve to someone in the first instance. Okay. If you have, okay, there's a condition called Barrett's esophagus. Heard of Barrett's? Okay. So if you've got a long segment Barrett's, for instance, your risk of developing esophageal cancer in your lifetime is maybe as high as 1 in 300 per year. Okay. That doesn't mean to say you can't do anything about it, or if you've had a sleeve that you can't do anything about that because you use the colon to replace it instead of the stomach. But that may be a relative indication. That's a discussion to have with an individual. Okay. If you've had, if you can't control heartburn with medication and tightening the hiatus beforehand, right, then that may lean you towards going on a bypass. Okay. But remember, the younger you are, right, the more you've got to live with the effect of a bypass, okay? And there's odd bits on Roux-en-Y's, okay? So there has to be a reason why Roux-en-Y's went down in the world, right? Because it was the most common operation done up till August 2015, right? It's gone like that since. Sleeve did that, okay? And part of the issue is people just present, right, with weird issues. They get abdominal pain out the blue, right? And you don't know what it is. So you have to scan them, CT, all of them, and even then, if they continue with pain, you've got to operate. You've got to look, because they can get internal herniation, okay? You get ulcers, you get bleeding ulcers, you get perforated ulcers. You're more prone to calcium issues, you're more prone to anemia, B12 issues, okay? Pregnancy, potential issue for herniation through the bit that you've replumbed, okay? And there's a peculiarity for Roux-en-Y bypasses, okay? There's two, well, actually there's 3 other bits, okay? The control of diabetes is probably better, and there's trials that have shown that, than a sleeve, all right? So you're on fewer medications to control diabetes. But it comes at a cost, and the cost is hypos, all right? And if you follow patients up, there seems to be a higher incidence of accidents on bypass patients, all right? And the presumption is that they perhaps have had a hypo, right? Now, you can get hypos with a sleeve, but you don't tend to be symptomatic, okay? You don't tend to pass out with it, right? But you get these drops in bypasses, all right? And of course, some of those accidents can be fatal as well. And if you follow them up, there's these kind of groups that just can't be contactable anymore, right? And that was an issue in the United States. So the other bit to them is if there's a history of any dependency, right, then there's a higher incidence of alcoholism after a bypass, a Roux-en-Y bypass specifically, okay? And it's a really curious thing, right? There were animal experiments on that. Rats will not drink alcohol, okay? They will dehydrate to death. You can put alcohol in front of them, they'll dehydrate to death, right? But if you do a Roux-en-Y bypass on a rat, it will drink the alcohol, all right? Just the Roux-en-Y. If you do a sleeve on it, do a single anastomosis, they won't, okay? There's something about a Roux-en-Y that we don't know, but there is that kind of element. So you know, there are those bits to think of going forward that are a potential issue. but it wouldn't be, I guess none of them are absolute indications to do a bypass as a front-line procedure. But it may sway you after discussion with an individual. You know, if they hear all the data and go, actually, I still want to bypass, okay, unless it doesn't make sense, then fine. If you've gone in with it with all the data at hand, you've made an informed decision, right? Don't persuade someone to have an operation they don't want, because you'll be on a loser, okay? It's been my experience anyway. So, so as a revision operation, then yes, uncontrolled heartburn would be an indication for a Roux-en-Y bypass, because you're taking the acid secreting area out of the equation. But if you haven't worked your patient up, then a quarter of those individuals that have had a Roux-en-Y bypass for sleeves will still have uncontrolled heartburn, okay, if they've not been worked up properly. There's a fair bit of that going on as well. All right.
How costly is the operation?
I guess it depends on who you go and see and what your healthcare fund is to a certain degree. If you are completely uninsured, you wouldn't get much change out of about $23,000, $24,000. If you are insured, it's probably for that entire 5-year package, you're probably looking at about 5,000, something like that. And the 23,000, that would be probably about 29 for a 5-year package if you look at it that way. So, depending on your healthcare fund. Any other questions? Yeah.
I've read that if you have diabetes, because of the damage that it does.
You'll have to speak up, sorry.
If you have diabetes, because of the damage it does to your cells,
Yeah.
it's better to have surgery earlier than later.
Yeah.
Do you agree with that?
Okay. Yes. You know, you can take that to the nth degree, right? So if you have an 8-year-old that's morbidly obese with diabetes, should it be the sooner the better? Okay. Youngest person that's had bariatric surgery in the world, 3 years old. Okay, in India. Okay, you can debate the sense in that or not. Okay, but so look, as a fully informed person, in general terms, the sooner the better. Yes. Okay. If you get end organ damage, so if you've had a heart attack, you can't improve that bit of the heart that's dead. If your kidneys have already packed up, then you can't resurrect those kidneys. If your nerves are already damaged peripherally, you won't get that back, okay? It's preventing further damage. That's all you can do, all right? And obviously, you know, the longer a system is not quite right, it's a bit like a car that's not been tuned, right? It kind of gets worse. You might not be aware of it, but it's getting worse, right? So, you know, that's the general terms. But you know, when is surgery right for a condition? When it's right for you, right? And it's really important. You know, all these decisions should be on an individual basis when it's right for that individual. Okay. I've had people come back 10 years afterwards, right? And they said, "Oh, I wish I'd done that 10 years ago." I said, "No, I don't, because you weren't ready 10 years ago, right?" But they've done that, and they've come to that kind of fork in the road, and that's a really important step. You know, if the outcome I want is there, that's the pathway, right? If you're not ready, don't do it, yeah, because you can't go backwards, right?
Is there an age limit that you say you can't have it after a certain age?
Never say never and never say always in surgery. I think each individual has to be, but obviously, look, you know, in simple terms, the older you are, the less benefit you're going to get, right? Statistically speaking, okay? And the higher the risk of surgery, statistically speaking. But it doesn't mean to say that there should be, you know, an absolute cut-off, right? There is in the public sector, right? But they lost their case, if any of you, they got taken to the age discrimination court and lost. They don't tell you that either, but anyway. So you know, essentially, although there are guidelines of age, right? So 18 to 70, right? But they're guidelines. They're there to guide, not to say 70 plus 1, all must stop, right? But the United States has an absolute cutoff, right? Okay, So insurance will have an absolute cut-off, and it will have a weight cut-off. Okay, so it's BMI 35 in the United States, okay? And I don't even think they have a racial discrimination bit on there either, okay? So I told you 22.4 is equivalent to 30, right? Don't pay any. 35 with a medically treatable condition, or 40. And you've got to do a supervised program beforehand, and if you don't jump through the hoops, you just do not get it, right? That is it, okay? That's not Australia. Clinically significant obesity is the wording in the book for Australia. Yes?
In regards to the hormone changes, does it change anything that could help or benefit with autoimmune diseases?
Yeah, it's a really good question. So once you've got an autoimmune disease, you don't not have it. You've got it for life, right? So you can have Crohn's or UC, and it may be quiescent for the rest of your life, or rheumatoid, and the burnt out rheumatoid may never come back. But you don't know, do you? Okay, so it's always got, it's always there. So obesity is a pro-inflammatory condition, okay? And so the more your immune system is geared up, you'd like to think that that would be beneficial if it wasn't then, right? Okay. I don't think there's any hard and fast data on that, all right? And I would also put to you, the more you do, so the bypasses and various other things, that you may be changing hormones in those individuals, and there may be vitamin issues, and you may be causing another set of potential issues depending on what people eat, etc. And so the weird and wonderfuls may start to be seen as well, okay? Time will tell from that perspective. But I don't think we should exclude that either, okay? And hence another reason for following people up, okay? Because you do enough, you see weird things, right? Okay. I had a complication from surgery last year that's never been reported in literature, okay? Happens, all right? I didn't like it when it happened, neither did the patient. He's okay now though, but it's horrible. It's just like, it doesn't happen. It does now, okay? Yes?
As a spin-off of that, I have lupus,
Yeah.
and I have medication for that. But as a backup, I often take Nurofen,
Yeah.
or Brufen. Now I know I've read you can't take that.
So bypasses, it's recommended not to have it from any bypass, okay? Especially a Roux-en-Y or a single anastomosis, okay? So if you're talking, which ones would I definitely not do it in decreasing order? So Roux-en-Y, single anastomosis, definitely not, okay? Then the hindgut operations, it's not recommended because of the risk of marginal ulceration, okay? Where you've joined the two bits together. You can have it with a sleeve. It's not a problem. It's just a smaller stomach, the sleeve, right? So it behaves in the same. So there is still a risk of taking non-steroidals with any stomach, right? But it's at no high risk, okay? So it's the same. So yes, you can take non-steroidals with a sleeve.
You shouldn't take?
Sorry?
With these sort of surgeries,
Yeah.
are there other drugs or things that you shouldn't?
No, you just need to be aware, okay? So you're a cheap date after surgery, okay? All right? But you'll also absorb alcohol really quickly, all right? Okay? So not only are you cheap, but you're going to be drunk really quickly. So you absorb quicker as well, okay? And you also absorb medication in a different way, because remember, it empties quickly, right? I've had a fairly prominent person in town, okay? His psychiatrist rang me after his surgery, okay? Saying that he's going doolally, right? But he swears he's taking his antipsychotic or his antidepressant medication, right? And what he was doing was he was on about, 6 or 7 medications, right? So the most important one is this one, right? In first, drink, down. Second one, drink, down. Third one, drink, down. By the time he hit the 7th, okay, the first medication was almost in his colon, unabsorbed, okay? So he had acute withdrawal from his antidepressants, despite taking them in exactly the same way as he was before, because it's a rapid emptying system, okay? So you have to take it with a minimal amount of liquid that stops it going out if it needs to start, okay? And you need to find that fine balance. And again, if you're on a whole plethora of medications, okay, and you have a bypass, you have a more unpredictable absorption of those medication. All right, it's harder to control. I'm not saying you can't control it, but again, take the two groups, sleeve group, bypass group, easy to control in the sleeve group, okay? But you still may have to modify the way you're taking things.
And will the dietitian help with that, or does the GP? Who
So physician, dietitian, and me, yeah, depending on who picks it up, yeah. Okay, but that's part of the reason for having, you know, as much workup as you can, right?
Yeah.
And you know, weird things occur, you know, they do occur, you know. People can get tablets stuck in the esophagus, you know, you can ulcerate from that, okay, and I've seen that too.
Obviously, when people have like multiple medical histories, does the surgeon then liaise with all the other specialists involved with that person's care?
Yeah. Look, it varies from, you know, I've got high blood pressure and I'm seeing so-and-so specialist. I go, yeah, all right. But remember, physician's going to give you a once-over anyway. To, you know, I've got gastric varices and I've bled and I've got, you know, high blood pressure and I've got low albumin and I've had a stroke and I need new kidneys to, you know, you get those as well, okay? And in fact, we're getting more and more of those, okay? It's getting harder.
It doesn't exclude you from weight loss surgery? Or does it depend on the severity?
Again, you have to take each individual on merits, okay? So you know, I've done a heart transplant patient, okay? Done several kidney transplant patients. I have done somebody with varices that I knew about. I've done somebody with varices that I didn't know about and came across them halfway through the operation, okay? Gastric varices from usually alcohol abuse, but you can get that secondary to other causes as well. They just get different pathways inside their gut and then the blood vessels expand up. So normal blood vessel, you know, that you see on here might be the size of my little finger, which is okay as long as you don't put a hole in it. Right? So it has a little bit more connotation. So in long answer to your question, I would look at most people that get referred, because they've usually had, these days, if you go back kind of 15 years, you know, Police Lead Joe blogs, BMI 30 with nothing, okay, and you kind of go, smoke 60 a day, you know, not really appropriate, all right? Now most of the GPs and other specialists are kind of more attuned, okay? There's still a few intransigent ones out there that just, you know, no, just eat less, don't, right? As a medical professor, we're not always quick at cottoning on, but they've usually been filtered out by the GPs, or they may just ring you, or they may send, look, do you think this is appropriate? And I'll tend to see the majority of those, just to have a chat and at least explain options, because there is more than one option, right? It's medication as well, you know. So.
I've just got one more, sorry.
Yeah.
Do you get staples as well as that cauterized?
Yeah, this is being stapled as you're looking at it.
Oh, that's stapled?
That's the stapler. There's examples of those outside. So there's 6 rows of staples on this device. It's 6 centimeters long, okay? And there's probably about, I don't know, probably about 150 staples in each fire of those. They're tiny, okay? And they don't set off any alarms. They stay forever. They're made of titanium and you can see them on an X-ray. Okay, and everybody asks those questions in some form or other during their period of time.
So titanium's not magnetic, it's not going to hurt in an MRI or anything like that?
No, nothing, no. And genuinely, they're very, very small, okay? And this particular device as well, this is the handheld, you know, version. I squeeze that with my hand. There is a new version of this now, which is a powered device, okay? And it gives you feedback automatically. So when you're stapling, especially when you're crossing staples, okay, it will feed back. And if it's too high a pressure, it will just stop. It won't fire, okay, which is a kind of big advance. And you can kind of look at the data, you know, as it fires. So, but this is the first instrument that you could move the tip like this, okay. Before there were solid instruments, and until this device came out, I couldn't do a sleeve adequately on an individual because it's a curved line, right?
On your literature and your PowerPoint, there was a mention of MASH. Will this assist in improving that condition too?
If you lose weight, all those that or they won't progress anyway. Yes, and you'll empty the weight out your liver. We're beginning a timeout by the staff behind us. Okay. If you've got further questions, I'm around. Feel free to ask them. But I think they're kind of telling us that the rental on the room's up. Thank you very much for your time. Thanks for coming. All right.